and this is the kickoff to this new year of this talk program that we do called Innovation at the Edge, hosted by UCSD's Office of Innovation. I'm Greg Horowitt, and I'm the Director of Innovation here. We put on these programs to have conversations with the community, particularly where we believe the technology sits at literally at the edge, the future of different things, and they're to stimulate conversations about what would happen if, or where are we going, and that's why we like to have the conversations with you. Now, it will, of course, today our guest is Dr. John Ayers, who will be talking about putting the public back into public health. But these are meant to be not just merely lectures; these are meant to be conversations. So after we kind of get through the upfront part of the presentation, we're going to invite each of you to engage in the conversation. This is live streamed, and if you want to watch these things afterwards, you can go to our YouTube channel, which is Innovation or UCSD Innovation. To learn more about the programs we have at UCSD beyond this particular one, it's go to innovation.ucsd.edu and learn about all of them. We do everything from educational programs to events and other kind of programs, but our primary purpose is to support the entrepreneurial process and to help these entrepreneurs take things from basically founder-led ideas to team-led companies for it. So without any further delay, I'd like to introduce you to Dr. John Ayers, who will introduce himself, tell a little bit about his background, and then he will introduce the topic we're going to dig into today. John?
Yeah, thank you for having me. I really appreciate being here. So today I want to talk about getting the public back in public health. And you might be thinking, well, what does that mean? Because you don't know how public health actually works. And it turns out, even though I went to the top epidemiology school, I didn't know either until I had a lesson that taught me it. And that lesson was, like all great ideas, I'm watching football at home on a Sunday. And I'm watching it, and I'm a little lazy, and I don't want to turn the game off. And I'm like, the TV comes on, the next show, of course, is 60 Minutes. And on 60 Minutes, they're talking about this product called snus. Now, who in here has heard of snus? I hadn't either. Now, it turns out what it is, it's like a Tic Tac that you use when you use nicotine. Now they call them Zen as a popular brand that they talk about now. But this is years ago. And I'm like, I have no idea what they're talking about. Like, what is this? And Leslie Stahl is on 60 Minutes. She's like, it's going to be a crisis. Everybody's going to be using snus. And I'm like, dude, I work in public health. I never heard of it. What are they talking about? So I do what everybody does. I go to the most fun website on the planet, which is the NIH Reporter website, where they report the money that we spend on research so we know what people are talking about. And I looked, and that year we'd spent $95 million on a snus pandemic. And I'm like, we're spending all this money, and I've never heard of it. Like, what's going on? Like, how do we know? Like, who's using it? So I start looking at the studies, and all the studies are like, well, we talked to 5,000 people, tried to find the handful that ever heard of snus or used snus, and we talked to them. And nobody's reporting the real question, and that is, are people interested in this product? Is interest increasing? Is there actual crises here? What's happening? And so at the time, we were working with a group at Google, and they gave us access to their search archives before they were made public. And I'm like, I want to look and see what people are searching for. And so the next day when I went to the office, I pulled up the data, and here's some of the data. And there you see snus. This is an old figure. You see snus written there in the middle. And it spiked, and it continued to go down now for more than like a couple of years. My apologies, I forgot. It had gone down for a couple of years. And while I was looking at all this stuff, I'm like trying to find about like tobacco products. And I found this thing called e-cigarettes. And nobody had heard of that either. But when I looked at e-cigarettes, they were being searched for about 30 or 40 times more than snus. The thing we're spending $100 million on, there's no interest in. Experts have never heard of it. But the thing I'd never heard of as an expert, everybody wants one. And so we wrote a paper talking about the discovery of electronic cigarettes and how they were going to come to market back in 2011. And we showed that this is not just true in the United States, but this is true everywhere. Australia, Canada, United Kingdom, there was this increased demand. And back then we called it ENDS, electronic nicotine delivery system, but e-cigarettes, what they call them now. And I'm like, man, this is crazy. Everybody's going to want to hear this story. Like, people want to know. Like we talked about snus. Like people's going to know about this. And so we throw a little report together showing these exact same figures I'm showing you here. We send it to the top medical journal, and I'm like, they're going to be back to me in 2 days saying, yes, we've got to get this message out there. And instead, I heard immediately, we don't want your message. NIH isn't funding research on e-cigarettes. So we lived in a top-down model where we're not driven by what the needs of the public are, or what's actually happening in the public when it comes to public health. We're deciding by what the funders or the quote experts already believe. See, they already know what the problems are without looking. And they're so smart, they already know the answers. That's crazy. And so I pushed back and I'm like, I know they're not spending money on this. Let's push back a little bit. And like, okay, we'll think about it. And then the expert at the leading medical journal wrote back and said, I talked to my husband, and he's in a gig band, and I go to some of his gigs. I've never seen anybody use an electronic cigarette. And I'm like, Jesus, this is actually how public health works. Right? Public health, the only data we have is my husband is in a jam band. I hope it was a good one. Hopefully it was, something like the Allman Brothers would like. But we eventually persevered. We published our study, and back, more than a decade ago now, that study became one of the most read studies in medicine that year. And we actually wrote a follow-up to that study, and I'm thinking like, okay, this is great. We're going to fix the problem. No more snus, right? We want to spend money on these things, electronic cigarettes. We want to figure out what the problem is, and we want to be able to solve the problem. Well, guess what they ended up doing? Spending a lot of money to do this. Well, they did studies that said, if you try an e-cigarette, it actually makes you want to go smoke a Marlboro Red. And that's why we need to regulate e-cigarettes, is because they impact the products we already are funded and already thinking to care about. And we don't care about that product at all. It's just a bridge device. Now think about it. Is this remotely true at all? That e-cigarettes cause people to use traditional combustible cigarettes? You don't need a degree anymore to know this. It's just you need your eyes. And that's firmly not true. Right? Only less than 1% of kids today have even tried a combustible cigarette. Nearly more are using nicotine, but via electronic cigarettes. So this wasn't even the case. And so the reaction was we had this top-down model where the only way we could view the world, even when presented with data, was through the lens that we already had. And you're thinking, well, John, you're telling me just one story. This can't be true for everything. But it turns out it is. There's actually been formal studies that show not only are we so committed to the ideas we already have and the solutions, that those ideas and solutions are false the vast majority of the time. Because if there's 20 of us and we all think that, X is a problem, right? We all think food insecurity is a problem among like college students. There's people that say that. I was at a meeting the other day and an expert got up and told me that 40% of the kids at an elite private school were food insecure. I'm like, you got to be crazy. Like, who would say that? But he's like, the data don't lie, John. We did a survey. We asked them. We asked if you skipped a meal in the last week, and 40% said they did. And I'm like, my Lord, that's everybody, right? We're supposed to do intermittent fasting. I should do more of it myself. So apparently I'm food insecure, even though I'm fat. So it's just crazy how we view the world. And when we do those types of studies, and we do them 20 times, or 30 times, or hundreds of times, we end up finding these outlier estimates purely by chance. So then it becomes ingrained as ground truth. 40% of kids at a school that costs $80,000 a year to attend can't afford food. So today, I want to talk to you to encourage you to reject this top-down model. Where we, the experts, know the problems and know the solution, and instead spend more time listening and responding to the public. And so the first way I want to talk to you about it is enhancing what we think we already know. Now, who in here has heard of seasonal affective disorder? Right? So we believe that your mental health symptoms of mental distress, psychological distress, are worse in the winter when there's less sunlight, and they improve in the summer when there's more sunlight. And it's actually a specific diagnosis, right? We don't apply this to all areas of mental health. We have a specific diagnosis we can make about seasonal affective disorder. And I'm like, where'd that come from? And when you look at it, it came from studies like this, where they did large surveys, and they just compared the volume of people that said they were kind of stressed out in the winter versus the summer. And they said, here's this effect exists. And I'm like, Well, that's weird. Like, how do you know it's seasonal affective disorder versus something else? And so we looked. And again, here we're looking at Google searches. And in red is Australia, and in blue is the United States. And each one of those lines is a years of data. And you can see there's a very strong seasonal pattern, right? More demand for people searching for, like, am I depressed? Do I have anxiety? Do I have some disorder in the winter than in the summer? And that's true in Australia and true in the United States over many, many years. And that's true for people searching for things related to depression. But it's not just depression, it's everything. Both AXI1 and AXI2 disorders, as we call it in psychiatric epidemiology, both including like ADHD, bipolar, eating disorder, schizophrenia, suicidal ideation, OCD. It turns out maybe there's something out there in our environment that's actually driving all our mental health, but we only have this top-down model where we think seasonal affective disorder and nothing else exists. But it turns out it's affecting everything. And when you think about it affecting everything, you're like, man, that's a huge potential there. Like, what could we do to improve public health if we have one emollient that could impact all the outcomes? What would that mean? And you might be, John, you're crazy. Clearly, these people are searching because smart kids at UCSD are in school in the winter, so they're learning about these things. And so in the summer, when they're home, they're not learning about these things, and you're just seeing an artifact. Or you're seeing, like, most new diagnoses for mental health problems actually occur in pediatric populations, not adults. And they actually occur where? The school. So you're just seeing a school effect. And I'm like, we can test that. So each one of these nodes in red or blue, red Australia or blue the United States, is shown, and we show their latitude. And what we're showing here is the difference in the effect, the peak and the trough between winter and summer and people searching for help for these outcomes. Here I'm showing you depression, eating disorder, and schizophrenia. You can actually see as you move further from the equator, and the effect of daylight is attenuated as you move closer to the equator or exacerbated as you move further away. Like Miami versus Boston, there's a difference in effect. So there's actually something bioplausible happening that's driving these differences, not just to explain away the outcome. One of the other ways I want to change the way we think about what we already know is everybody in the room has heard of physician diagnosis, right? You typically go to the doctor and hope they get it right. Or if you're smart, you might try Dr. Google and do a self-diagnosis. And you could do that. And I'm like, what do? I got friends that are smarter than me. I'm the dumbest one in the bunch. So I'll ask them. I wonder if regular people do that too. So we did a study. We published it in JAMA a couple of years ago. And we want to look at people's interest in getting a diagnosis. Like, do people go online and get diagnoses from their friends and peers on social media? Would you go to Facebook or Twitter or Reddit to get a diagnosis? And so we picked a very extreme example for this, and that is people trying to get a diagnosis for an STD. When people go online and get a diagnosis for an STD on social media, and it turns out there's places that exist where folks might be comfortable doing that. One of those places is Reddit r/STD, and here you can see, a few thousand people use it. I think cumulatively over all these years, we're talking like 15,000 people posting to Reddit r/STD. But when you look at the actual content of those posts, it turns out the vast majority are people trying to get a diagnosis from strangers on the internet. I'll read you one here. This first one, it's like, is this an ingrown hair or genital wart? I went to the doc a few days ago and he said it's genital warts. I'm forward because, I'm always careful. This is not me. I always use condoms. But I recently shaved, and the doctor could be wrong. I bet you it's an ingrown hair. Here's a pic. It turns out about 1/3 of all these posts included a pic. And they're like, I'd appreciate a second opinion. And so here we can see this person is trying to get a crowd diagnosis. And like I said, the vast majority did. I think about 2/3 were trying to get a crowd diagnosis. But a large plurality of those, about 1 in 3, were getting a second opinion after already seeing the doctor. And so they're going online and saying, my doctor might be wrong. Can you help me out? And you can see why they're doing it. They're getting lots of replies, and they're getting replies very quickly. But you can also see there's some danger here. Like, here's a person that had HIV confirmation test. So we use the same sample, but we repeatedly test it, and sometimes that sample will degrade, and we need to come back in and get a new sample. This person had that experience from their doctor, and they're like, I got to come back in because it's showing positive on the test that we have. What do you think it is? And of course, the crowd helped them out and gave them their answer. Now, here's a picture that the news used of our research team looking at the pictures in the study. And this study was widely popular in all the media. And it was also published in the top medical journal. And I'm thinking, like, why would they want to talk about this? And the reason is not because they wanted to help people that were searching for help with diagnoses online. They want to shut it down. We can't allow this to exist, right? We're the experts. Shut down this. And so we the experts, have been living in a proverbial field of dreams, where we believe that the public will come to us, use our selected channels and pathways to get help. Otherwise, they're not deserving of our help. And we said the exact opposite when we published the study. We said, actually, no, we should go to them. Right? We spend all our time going like, I wonder if people would care. I wonder if people would seek out help. Here's people already caring, already seeking out help. It's indicative of a larger phenomenon, but it's true of even exaggerated outcomes like STDs. But it's going to also be true of AFib, right? It's going to be true of all sorts of outcomes. Why don't we go to them and help them? And so that's what's engendering a bottom-up approach, right? Helping the people who are seeking the help. I want to talk to you a little bit now about opportunities and a way a bottom-up method can help us identify and respond to needs that are being talked about in the public. You know, how to be responsive. So instead of going about it traditional way, which I showed you, which is, oh, I have an idea, I'm going to look at this idea, I just, it's kind of like, just a flash in the pan, and I'm like, I got this idea, let's test it. Let's actually respond and seek out opportunities in the public. And what's probably one of the biggest things happening today when it comes to like people and health and how they treat their health at home is CBD. And everybody's crazy about CBD. Here's internet searches, both in aggregate and by state. You can see they're going up tremendously. We estimated that during a typical month, about 1.3 million people will search for CBD on Google in the United States to try to figure out how to buy it or use it for their health care. And to understand what that means in context, because you're like, well, is that a big number or a small number? We can compare this to other topics. So what's the one thing everybody thinks about all the time? Diet. For every 2 people that search about diet, 1 person's searching about CBD. CBD is more popular than exercise, meditation, vaccination, acupuncture, all these other alternatives. It's extremely popular, and people are using it or seeking it out and potentially using it, and we're not really talking about it. Now, when this study came out, it got a lot of attention, and I remember watching C-SPAN. It doesn't come on after football, but sometimes I see it. And Scott Gottlieb, the then FDA director, was talking in testimony, and I think it was a senator from Tennessee. He said, listen here, Dr. Gottlieb, did you see this new study? CBD is really popular. Now, I don't want to say anything bad about it, but what do you think the FDA should be doing about CBD? And so they asked him, and he said, the FDA would take a stronger regulatory action against CBD, if patients who are diagnosed with conditions by a doctor were using it instead of using the therapeutic they were prescribed. And I'm like, man, we can answer that question really quick. We don't need to wait 5 years. Now, when he said it, remember, he's living in what? The old world. And he's like, that means you need to appropriate another $100 million. We'll give that money to smart people at UCSD, at Hopkins, and Harvard, and they'll figure this out 5 years from now. And I'm like, actually, we can just go where people are talking. And so we did just that. We went to Reddit, to RCBD. And here's some example posts. Like the first post is like a post you'd think you would see, right? Is there a legal CBD supplier that can ship to Indiana? They're looking for this product, and their parents have used it, and they want to get it. And you're like, okay, they're just interested in talking about, some process issues with it. But then when you look at the second one, you can see like, oh, I'm currently using this product. I've tried samples of it, But I've noticed this product gives me more energy. Can anyone explain the difference between this product and the other? And so they're using it like for wellness. This isn't for a diagnostic condition, but they're using it for wellness to like see if they can feel better, have more energy, think clearer. But then you see the bottom examples, and it's like, oh, my integrative physician, that's not a real kind of doc. This fake doc told them they should use this product for general anxiety disorder, a CBD product, and they're interested in the dosing and if the dosing sounded correct. And so here we see people actually testifying how they're using the product, what condition they're using the product for, and if they're using the product because their doctor diagnosed them with a condition that they have. Or you can see people using it like for both. And when you look at that data, we broke it down and we said, here's the categories like of, just a general search, people searching for physical wellness, people searching for psychiatric conditions, people searching for conditions and wellness as well. This person using it for anxiety disorder. This person was using it for depression. And when you look, you'd think wellness would be very popular, and it was very popular. People are using it not, as a therapeutic, but using it just to feel better. And we can see about 1/3 or about 30% of posts in total were using it for wellness, typically mental wellness, like, I just want to feel better, more clear-headed, it makes me more relaxed. It's not you don't have a diagnosis, right? You're just using it to feel better. Or they're using it for like physical wellness, like more energy. I'm taking it as like a supplement. We allow supplements to be sold over the counter. You can go buy anything you want over the counter, use the supplements, very, very, very lightly regulated. But it turns out the other 70+% of posts where people actually using it for diagnosable conditions, would have been diagnosed by a doctor, and they're using this medication, CBD, not a medication. They're using CBD as a substitute for their medication. And so we can see people using it for psychiatric conditions, orthopedic conditions, talk about the spinal arthritis, sleep, like insomnia, GI, gastroparesis, they're using this, addiction, even using it for ED, which is interesting because that's a side effect of CBD. It causes erectile dysfunction, but they're using it to treat it. But then like cardiology, right? So if you live to be the age of 80, I hope everybody does, you got a 50-50 chance of having AFib, an irregular heartbeat. The problem is it causes strokes. So we put you on blood thinner. Would you think that an 80-year-old would be out there going like, I'm not going to take this blood thinner because when I cut myself shaving, I bleed a lot. I want to switch to CBD. Like nobody a priori would be thinking this, that this existed at this level, and this is why most people are using these products. But it turns out they are. Everybody's taking CBD, and everybody's taking it as a medicine instead of as a wellness product, which is what they thought out the door. Now, I've told you about how I learned how public health actually worked and how we can improve what we think we know and how we can make new discoveries, responsive discoveries to what's happening, participate in the larger debate and do so rapidly. I want to tell you some stories now, and these aren't in a braggadocious way, about where work using this bottom-up framework actually saved lives in a quantifiable way. And we'll talk you through some of those examples. The first is Charlie Sheen. Now, people remember when Charlie Sheen was diagnosed with HIV. He went on the Today Show with Matt Lauer, and he did the opening top of the hour interview, the most viewed hour. He said, I have HIV, and he came out and he talked about it. Why was he talking about it? He was being blackmailed, right? So he was being blackmailed, and his sex partners were going to tell on him because they knew he was taking HIV medications, and they knew they themselves were taking PrEP. So they're like, I'm going to tell on Charlie Sheen unless he pays me. So now he's got to come out and say it. So when he comes out and tells a story, right, Charlie Sheen's not talking about public health. And Matt Lauer is going to talk about the sensational nature of the conversation. He's not asking questions about public health. But I remember, because I'm a little older, when Magic Johnson was diagnosed with HIV. And it was radically different. Like people were saying, like, can you shake his hand? He'll be dead in a year, right? He can't play basketball. Like nobody knew anything about HIV. We'd had, Arthur Ashe and then Magic Johnson, but Magic Johnson much, much more high profile. And so nobody knew, but for 20 years now, before Sheen came out, we had known. We had these ABC programs, always be careful, right? So we taught people, use condoms, get tested. Think about the signs and symptoms, right? Because it's going to be like a bad fever. Acute onset will be like a bad fever. You may think you have a really bad cold. Think about that. Look out for that. Get tested if you think you've been engaged in risky behaviors and you have those symptoms. So people knew kind of how to respond. Now you can imagine this story was very popular, and of course it was. Here's news articles in blue about HIV and internet searches for HIV generally, and they both reached all-time highs at that very last point on the chart. News was about 265% above what you would expect, and internet searches were up about 400%. But with that always be careful framework, could people be responding in that way? And it turns out they were. These are searches in 15-minute interval bins. And you can see, let's start with the bottom two panels, the D and E. You see people searching for HIV symptoms immediately when Charlie Sheen discloses his status. Immediately. And that actually that effect has a duration of about 3 days. You can also see with HIV testing, where people immediately, as soon as he's disclosed, a huge spike in interest in testing. And again, that effect lasted about 3 days. Now, condoms is a little different. Most people at 9 a.m. aren't thinking about sex, unless you're interesting, and then maybe you are. Instead, there's a very strong circadian pattern. And when you start to think about condoms, around like 10 p.m. to 11, that's when that spike starts to go up, and it peaks around 1 a.m., and then it goes away. It has that same pattern every day. That night, we saw an increase way above what you expect, because that night maybe people were thinking like, oh yeah, Charlie Sheen, I should definitely think about condoms. Need to go on Amazon, get a condom. Where to get them at? I got to think about this. Now, we published a study rather quickly in Medical Standards. I think this came out maybe 5 weeks later after his initial disclosure, which the top-down model is like 5 years, right? You got your idea, wait 5 years, have the answer. So we're doing it in like about a month. And when it came out, of course, the study was very popular. It's about Charlie Sheen. And so it got a lot of attention in the media. Charlie Sheen himself came out and spoke about it. And it's like we don't have to imagine if we knew. We were kind of knowing in real time. And so by simply saying we hear you, maybe the public was responding. We was creating like a free paid ad campaign for condoms and for HIV testing. And it turned out that free campaign turned into a real campaign. I did the Dr. Oz show. I'm pretty chummy with his CMO. We're good friends, Michael Krupian. And he's like, John, we're looking for things. And I'm like, you know what? A condom company came to me. We should do a commercial. And so we did. We did a commercial. I'm sure you can find it on YouTube. I'll be in some of the commercials. This is the one where we filmed it up in the valley, up in Encino, and promoting a new condom that was very expensive at the time, a new technology. It's now more mainstream, called Lilo Hex. You can actually buy it at Target and Walmart now, but back then it was very expensive because it won like an X Prize for condoms, where it prevents STDs, but feels like you're wearing lambskin. So it's very popular, very new to market product. So they tried to promote the product, and I remember doing this, and it was really moving because, like, in this video, I remember like Sheen's crying and saying that the worst thing that ever happened to him now could be something that was good. And now we can do good based on a bad outcome. And shortly thereafter, a company called OraSure, they make HIV testing kits. And the testing kit's called OraQuick. You can buy them at Walgreens. You can buy them on Amazon. You can buy them everywhere. And they came to me and said, John, we get barcode data that's delayed, right? Because publicly traded companies are selling our products. So if we have information on people who are buying it, that's private information. So they delay it, until after they do their quarterly reports. So next quarterly report, we'll have data from Walgreens and all the different retailers, and we'll give you that data, and you'll see what the effect is. And I'm like, the reason Alphabet's a $1 trillion company is people buy what they search for. I kind of can guess that. And sure enough, we saw that. The lowest level of aggregation they would allow us to do was weeks. And so testing that week was elevated about 150%, which actually represents like the mean effect, like if you average over our 7 days of searches. But I'm like, I want to see the effect of the Charlie Sheen effect. And that is when we published our study, what did that do? And so it turns out Charlie Sheen's disclosure is the all-time high in HIV testing sales. It's like 7 times higher than National HIV Testing Day. You know who's number 2? Us. We didn't need $1 million or $100 million like they did for snus. We needed years to think about it. Just listening to the public and letting the public know we hear you created this echo effect that outlived all the other effects that we spend money and energy planning. But just having our ears to the ground, we're able to engender that kind of effect. Another example of one we did was on Pokemon Go. Now, who remembers when Pokemon Go came out? Pokemon Go was really popular. All the experts loved. Shall I let this guy in? Come on in. We welcome everybody. So, Pokemon Go came out, and all the experts loved it because it meant reporters wanted to talk to them, and they could tell their story. And their story was, as an expert, like a Tool Butte, he goes, wow, it's going to get a lot of people walking, and it's going to make a lot of money. And I'm like, I don't know about this. You know, I'm seeing all this stuff, and I'm like, I'm not in the greatest of shape, so it'd be hard for me to run around and catch all the Pokemon. But what if I got my red sports car? I could beat everybody, and I get all the Pokemon before anybody else. And I'm like, man, I wonder if people are doing that. So the week that the product came out, we waited for 1 week of data. And yeah, you know, Apple has accelerometer data, and we actually have done some studies on that. But at the time, because we didn't negotiate a relationship at the time, we're like, we had to use other data. So what other data could we use to try to figure out if people are playing the game while driving? I'm like, what's the one thing everybody loves to do? Tattletale. And what's the internet for? For tattletelling. And so the first week of the game on Twitter, there was about 350,000 tweets that mentioned Pokemon Go while driving and playing at the same time. And here you can see an example where somebody's tattling and they go, oh my God, I'm catching Pokemon Go and driving. My mom just legit stopped the car in the middle of the road to catch a Pokemon. Or people or passengers are playing and they're distracting the driver. And they're like, I just made my sister drive me around to find Pokemon. Or you can see people talking about pedestrians interacting with traffic. Where like I just saw a kid get clipped by a car trying to catch a Pokemon, or I almost got hit by a car playing Pokemon Go. And you can see people tattletaling on each other. And when we look at this data, about 1/3 of just 350,000 tweets. So think about what that means. In the first week of gameplay, we're talking about 140,000 tweets, 130,000 tweets, talking about playing the game while driving, or as a pedestrian or a passenger, or a pedestrian interacting with traffic. Like that's the most common modality of people talking about it. Is like they're playing it the worst way you could play it. Well, maybe the best way if you want to win, but the worst way you could play it for your health. Now, our study came out, and fortunately, gameplay was made safer after our study. The CEO of Niantic, the game maker at the time, reached out. And, you know, of course, they want to make money. They don't want to kill people. So they're like, how do we fix this? And we're like, well, you actually have, as an app developer at the time, you have accelerometer data. You can collect, that's available to you, collect that data, and restrict gameplay at driving speeds. And that's what they did. You know, if you were going above a speed that they thought a pedestrian couldn't run quickly and do, and you kept that pace up, I think the speed was like 25 miles an hour. You did that for 1 minute. That was your average speed. Turn off the game. You couldn't play the game for like 5 minutes. And so, again, we didn't need someone else to come along and fix the problem. We could just identify a problem early and fix the problem within like a week. I think the time frame from when we did the study and it came out was probably like 7 weeks. So 7 weeks of like where this problem existed before we addressed it. More importantly, the solution was actually codified into law in certain state legislators. I think in Oregon, for example, they passed legislation that meant if you'd made augmented reality games in the future, you had to build in these safety features to prevent playing it while driving or as a pedestrian, which was pretty cool. Now, augmented reality games didn't become super popular. They may make a comeback, but it's nice to know that now game makers, when they design games, they're thinking about these health cost offsets, and legislators are, and not just looking at it with the rosy picture I got to say what the news reporter wants to hear because I got to be in the New York Times. Now, how many people in here remember the TV show from a couple years ago, or I guess 4 years ago now? COVID really changed the timeline, called 13 Reasons Why. People remember that show from Netflix? It's based on a popular book. And my buddy Howard Koperlitz, who runs the Child Mind Institute, he and I were talking. He's like, John, this is crazy. They got this show coming out, and it's going to be about a girl that kills herself. And I got a feeling this show is not going to follow these WHO guidelines. You're like, well, what's WHO guidelines? Well, there's this thing called copycat suicide. And that is when a celebrity commits suicide, suicides go up based on death records. It's actually a really strong effect. Did you know when a suicide, econometricians love this, because it's the type of data they can use and it's publicly available data. Single occupant motor vehicle crashes that result in fatality, they go up after a celebrity kills themselves. So there's a huge effect of copycat suicide. And so to mitigate that effect, what do we try to do? We create guidelines, and those guidelines say, don't talk about the suicide that much. Don't make it the center of attention. What does the show do? For those who don't know, the show is about a girl that commits suicide, and it follows her trajectory. They also say, don't talk about the modality. Don't talk about the method. Right? Don't paint suicide as a solution to your problems. Make sure we frame this negatively to try to prevent these copycat effects. And that show, like I said, did break all the rules. The opening scene, when I went to watch it the day it came out, is a locker room. And it's a memorialization on a girl's locker where she's already dead. Yet in the show, she continues to live. She engages with her boyfriend, and he regrets being mean to her. She still goes to the prom, has a great time. Her parents love her more, and she learns that her parents loved her more. Breaking all the rules, and then on top of that, many more. And so here we looked at internet searches related to suicide. So I think this is all searches on Google that have the word suicide in them. And so we can see that suicides definitely went up greater than expected. We're using like a synthetic counterfactual. So what happened and what we expected, and then we can see this increase. And it was a rather dramatic increase. I think searches were cumulatively about 40% increase, representing, I think during this time frame was about 3 weeks. I think we represented an excess of like 50 or 60,000 people searching for this. And you're like, well, John, of course searches for suicide will go up. The show's about suicide. And that doesn't mean anything, right? That could be a good thing. Searching for suicide hotline, I guess. Still thinking about it. It could be the bad thing, the way you're framing it. Well, I'll show you some exact queries. This is a random sample of some exact searches. What do we see? Suicide hotline, suicide prevention chat, suicide chats. They actually went down compared to what we expected. What went up? How to kill yourself, how to suicide, commit suicide, how to commit suicide, people actually engaging in a suicidal act. And we call that professionally suicidal ideation. You can see people actually thinking about killing themselves. And when we did this study, I thought, man, maybe we can help fix this problem. We gotta do something about this. And the experts who live in the top-down world, here's what they had to say about our study. The head of the Society of Behavioral Medicine, that's the leading psychology group, professional psychology organization in the United States, she said, this study does not demonstrate to show causes of suicide, just Google searches, which is not surprising at all. Sean Young says he wrote several popular books in the academic presses on suicide. Don't get freaked out. This show is it isn't causing people to go kill themselves. But what the hell? If that's your kid and they're searching on the internet how to kill yourself, do you think that's just increasing the discussion that we need to discuss? See, our top-down model makes us so blind we can't even see harm when it slaps us in the face. And I remember going on one of the morning talk shows, and it's before COVID, and so you'd have to go downtown. and they set you in a little room in a basement, like CBS or one of their affiliate studios. And you sit there and you're on a little chair like you're on. And you look into the camera. You have your little earpiece. And you're listening because it's live. And so you're talking to the producer to make sure your volume's right. But then you start about a minute and a half, 2 minutes before you go on air, you can hear what they're talking about in the studio, what's going out live on tape, on a delay. And I remember the guest before me was a dad who had found her kid dead by suicide. And on the screen, it was, do you want to continue watching the program? And the experts tell us, don't believe the data. We know the problems and we know the solutions. It's pretty sick. I was tried a lot, of course, we don't censor in America, but we tried to push Netflix to do something about it. I remember a friend of mine who works in the entertainment industry set us up to go meet with Netflix. And we went and, golly, they were just like, well, the experts told us. They told us. They told us not to listen to you. And we're not going to. And it took weeks and weeks and weeks, and finally they added a warning to the program based on our study. And the warning video gave you the suicide hotline. So maybe if this negative effect it caused, like people could still reach out for help. But what did the top-down model do? They did what they always do. They went and begged the government for money, or a rich guy, paid themselves more money, designed a study. This study was on people admitting to the ER with self-harm. And they go, yeah, John and them, they're right. 646 days later, after they get their little piece of the coin, what's it matter? The harm already happened. The top-down model does not work. And when that study came out, I was really surprised that they let us write that. We told them to go screw themselves. And we're like, ignoring data exacerbates these tragedies. We got to do better. We got to listen. We got to respond to people when they need to hear us. Now, how can we fix this problem? Right? How do we fix this top-down problem where we know the answer, we know the solutions, we have the data that we're already getting paid to collect, and that's what we care about? How do we solve that? And one of the ways I think we can solve that is by reducing the barriers to doing this type of research, right? So how can we make real-time and accurate data accessible for everyone? And that's one of the things I think you can do. It's one of the things I think we're trying to do. Remember our Charlie Sheen study? I told you searches went up. I told you sales went up. We knew those at different time intervals. Here's searches and sales data. Each one of those lines is an individual search, and we can see that those searches have a strong concordance with HIV testing sales. And we can then build prediction models. Here's some different models, and we're comparing different models. You look on the model on the far right, what that's saying there is we can predict based on prior searches future values of HIV testing sales, and we can do that and predict within plus or minus 250 sales a week, which is an error rate of about 4%. Pretty darn good. And we can actually take this data and make it available to people because that sales data is proprietary. We can now make this surrogate available. So instead of people before only had this black line, now they have the larger time trend and they can see what's happening just now this week. And we can teach people how to use this data. And we explain like, hey, you know what? You don't need to have a question. You can do data-driven analyses. So here's an example where we're looking for anomalies. And so each one of those red dots is an anomalous spike. And you're like, yeah, John, what are you going to find there? You're going to find like HIV testing day is a big deal. World AIDS Week is a big deal. Yeah, but it turns out that's only about a slight majority of all those anomalies. These other anomalies are events like the Charlie Sheen effect, and they're happening and nobody's talking about them. Like the one happening there in late last year in 2023, that spike there that was, substantially above what you'd expect. That was an outbreak of HIV in New Mexico at a spa where they were doing vampire facials, doing small needle pricks on the face and accidentally pricked themselves, didn't realize they had HIV, and then that person and several of the people after ended up acquiring HIV. But that event happened in the news, and guess what that did? It caused everybody nationally to want to go out and get tested for HIV. And so one of the things we're trying to do is make this data available. And so on your phone or on your computer, you can go to like hivtrends.org, and you can download real-time data on predicted testing for HIV. And we're building out an entire suite where we're going to provide real-time data on like depression or suicide. I think depression's underway. Tharva's working on it there. So we can also equip people in different ways to think differently. Now, I told you this top-down model. One of the ways this top-down model is so protected is because the standard of evidence in medicine is, for observationally, is cohort studies. And what a cohort study is we follow a group in a community or in a town. We follow them long-term, and we can learn things. And we learn, and like the classic one is Framingham, Massachusetts, the Framingham study. They followed those people for now going on 50, I think it's on the 60th anniversary. 60th anniversary is coming up in Framingham. They follow these people, and you can see things like high cholesterol predicts MI, heart attacks. And you learn these things, and they become actionable. The top-down model, though, guess what that means? You have protected data. Only you have access to it. Nobody else has access to it. You know, you run your cohort study, nobody else can use it. So you want to make sure to ask the questions you care about first. And I'm like, well, why don't we democratize this data by giving people access to cohorts by building what I call digital cohorts? Now, here's an example of on X currently, formerly Twitter, people talking about vaping. Now, we just said all you had to do was have the word vape or vaping in your tweet. And when you look at that, you can see large numbers of people have narratives like where they talk about it 10 times. Like 10 times in their tweets, they've mentioned vaping or vape, or 20 times or 5 times. And it turns out, instead of like having a snapshot, we can build a digital cohort and follow people in the digital community, in the digital town square. And we did this, and we built a 43.8 million person days of observation. Now what that means is we followed that many people that many days. And it's really groundbreaking. I mean, before that, the largest cohort study is going to be, like a couple million. So we're talking exponentially more. And here's an example of the type of data you'll see. This is somebody in our study. You can see the first time they talk about vaping is she's like, I got my vape today, and I'm so happy. You can see like 24 days later, she's talking about she hotboxed in the car. 45 days later, you can see this person's like, I feel very out of place. My vape dies. They're starting to get addicted, But then they're still, a couple days after that, their dad's like, do you really need to do this at the dinner table? Like, maybe you got a problem. Let's not do this. But then she's not hearing it, right? 52 days in, she's like, I got the hottest new vape. It is stunning. OMG. But then, right, now we're about 5 months in, she's like, oh, last night something happened. I don't know what in the hell happened. She can't find her vape, and she's having these bad experiences. And now she's starting to be addicted. She's like, my vape, I have 3.5 hours at work and my vape died. Oh, God, what am I going to do? I mean, she's talking about her addiction, right? Continue to talk about addiction. But she's still excited. She's still enamored with vaping. And we can continue to monitor her tweets. And we can see like, oh, nearly a year later, she's like, when I started vaping, it was just for fun. But now I know I'm seriously addicted and I need help. And we can see a little bit later, nearly a year and a half later, she's like, I really should stop vaping. I'm straight wheezing for months. She's starting to experience adverse events associated with her behavior. This richness of detail has never been available before using this framework. People do social media listening, like companies like Brandwatch, formerly Crimson Hexagon, Cambridge Analytics. But treating it as cohort studies, as repeated observations of the same individual, we don't do, because if it's marketing, right, you just care when you're thinking about the products, I can sell you an ad. But in health, we can use it differently in this way. And we can see her try to quit, and she fails. She's successful for 2 weeks. And we can now start to look at the cohort and learn things about the cohort that we couldn't learn. Like we can see like how many people had an intention to quit. And about 5% of people said they intended to quit. How many people made an attempt? Maybe they didn't mention they were intended, but like we can see large numbers of people make an attempt. And we can see like if their attempt is successful or not based on their history. And we can see like, oh, the first attempt works about 1 out of 4 times. The second attempt about 1 out of 3 times. So we can see like how many people are actually still engaging with the product. And so that's the way we make change using a bottom-up model sustainable, is we build the infrastructure. And for an audience like you, it's how do we make public health sustainable as an enterprise? The top-down approach has the billionaires, Gates and Bloomberg, Arnold. They got the government. The bottom-up requires an enterprise model. We got to figure out how to make public health analytics, how to make doing good a good investment. That's what we got to tap into to make a difference in this model. Thank you very much.
Question. I think you want to know what it contributes to the conversation. When you stand up, I would ask you to. When you stand up, I'd ask you just to kind of give your name and any important information like an affiliation or whatever that might be helpful. Everyone's too shy in here. No one's got a question? Okay. State the question and I'll take the microphone back up.
Sure, thank you. Hi, my name's Heather. This is amazing research. I got my master's in public health back in 2013 from Columbia, and this was long before there was a lot of information like this available on the World Wide Web. So the way you're harnessing it is amazing. One of the questions that I have is related to what you presented around people getting second opinions, essentially, from Reddit. And I'm wondering if you've seen any data internationally where that number is still kind of what it is here in the United States, or if you would posit that potentially access to healthcare in the United States is too difficult to maybe go get a second opinion from the health system, so you go to things like Reddit or the internet.
Good question.
So I'll answer your question, and I'll say I don't have a specific answer to you for that. And I'll say I don't know, but clearly the internet's multilingual. Before working at UCSD, I had a startup company that did media monitoring, and we actually collected data like this in 23 languages. There's every language spoken by 1% of the global population. That's why we picked 23. And I would tell you that from a surveillance perspective, the value add of these types of data is greater for the global south than it is for the west, because you go from no data to some data. And then you have to change the type of data that you use. How many people in here know how the H1N1 outbreak was detected? Remember the 2013, you had a pandemic influenza. It was detected by reading blog posts from Mexico, because the infrastructure at the time didn't exist in that community where people could self-report. But news reporters are what? They're like investigators. And they're going out and they're seeing this like, well, there's this flu, and people that work with pigs are getting it. And at the time they didn't know that then, but retrospectively they could be like, oh, we can pinpoint the village that flu came from based on these reporting from reporters, right? Treating them as independent investigators. That's definitely one way that this data can be more valuable in more resource-poor settings. Next. If you don't have anything, I have something else. I have a bonus. You want a bonus?
Okay.
You want a bonus? We'll give you a bonus. Okay. Here's a bonus. This is something we're actually working on now. So if you're smart, come help us with this now. So last year, we wrote the most read study in medicine. It was on AI, and it was on AI in healthcare. So it's not relevant to public health. It was the one where you probably saw in the news where like, ChatGPT is better than your doctor. That was us. So we compared doctors head-to-head with different chatbots. And chatbots were like 7 times more quality and like 10 times more empathetic. No duh. Like, doctors aren't very good via email. You need to kind of go in. But I've been thinking about how can we use AI to save lives? How can we use AI to save lives without going through a healthcare model? And it reminded me of some work that we did years ago now. And years ago, we did this pairs of studies where we asked Siri, I want to kill myself, to see what Siri or Cortana or Bixby would say in response to that. And guess what? Siri was very confused. You tell Siri, like, hey, my husband beats me. It's like, I don't know what you're talking about. You go, I want to quit smoking. It'd be like, here's where you can buy cigarettes cheap near you. And so we saw that and we're like, man, this is crazy. You can just, do a patch of a solution, right? And at the time, technology wasn't sophisticated. So we did these pairs of studies, and these studies came out. Actually, this other was at Stanford with Miner. We did, these studies came out, and guess what? They're like, part of the appendix was we put a list of 1-800 helplines that exist. So like if you go on your phone right now and pick it up, go, I want to kill myself, it's going to be like, hey, here's a 1-800 number, you want to call it. So we kind of fixed the problem. We put a patch on it, but the technology then wasn't available. So what could a Siri that's powered by a GPT model, how could it save a life? Any ideas? Like you get Siri to do one thing for you, or Cortana, or Bixby, what would it be? People who are close to you. I could create social support. That could save a life, right? We could get you more social support. That's true. Those are famous studies from Carnegie Mellon back in the day. The more friends you have, the longer you live. Some confounding with that. That's definitely true. So I was thinking, what's the one thing that I can immediately do I've never done and I don't know how to do? CPR. And so I did it. So we're working on a study now. So we went and we asked different conversational, we asked Siri. And Siri's like, I don't know what the hell you're talking about. We asked Google, how do you do CPR? The top links, on Google and Bing are like, here's news articles talking about CPR. There's no one box. There's no prioritization of information. You ask ChatGPT, like, how to do CPR? It's going to be like, yeah, you shouldn't do it because you're not trained. Just let that fella lay there and die. And this effect could be profound. Do you know when you're in critical care in the ICU, your distance from the workstation predicts if you survive a code? Your provider is having to walk an extra 30 feet that delays early onset of CPR, predicts mortality. Why don't we have an open source solution to this where if you ask Siri, or you ask Google, or you ask ChatGPT, it creates a prompt, triggers a prompt that will conversationally guide you through using CPR. And so it's going to tell you, do 120 chest compressions a minute. It talks you through it. It goes, do them 1, 2, 3. Lean their head back, open their airway. We've actually stepped back from the recommendations we do for CPR to try to make people more interested in doing it, not because it's more effective, like breathing. People will tell you like the giving breaths doesn't work, but that was actually because like people didn't want to kiss somebody. So they didn't want to do it. But like if you have something talking you through it, we can put the best practices in it. We don't have to remove them anymore. We can put them right back in it. And so we're trying to work on an open source multimodal solution, using different wraparounds, like different RAGs models with like Llama and GPT to make it possible to create the infrastructure where, Google, OAI, they don't have the expertise now to do this, but we can design a system that they can implement and do it for free. And doing so, actually use AI for the first time to save lives. So if you're interested in working on that, do come talk to me. We work on a short schedule, but we're hoping to have a solution in the next, this idea is like 3 days old. So we'll have a solution probably in like another month. So it'll be cool. Thank you again for having me. Really appreciate it.
That was awesome. Staff to come up and talk to John to learn more about the programs we're doing. As we say, go to innovation.ucsd.edu, and of course, this video and the other ones we've done will be on our innovation YouTube channel, which is UCSD. Is it UCSD Innovation? Excellent. And of course, we at the Office of Innovation are always here to kind of assist you and kind of help in helping you access resources related to entrepreneurship and innovation here on campus and in the community. So we look forward to this being the beginning of a conversation rather than the end of one. Thanks for coming, and please join me in thanking John once again. And we hope to see you next time. Thank you.